Welcome to the TOEFL listening section. In this part, you will hear one or more conversations in an academic or campus context, such as a discussion between a student and a professor or between two students. You may take notes while listening. Listen to part of a conversation. You will hear it only once, so listen carefully. After the conversation, you will answer questions about what you heard. Some questions will ask you about main ideas and details. Others will ask about implied meaning, speaker attitude, or how ideas relate to one another. Use both what is stated and what is implied to answer.
Good afternoon, Dr. Morales. Thank you for meeting with me during office hours.
Good afternoon, Jacob. How is your literature review on biomaterials and dental restoration coming along?
It is coming together, but I have some questions about new compounds for fillings and implants. I want to make sure my scope is accurate and clinically relevant.
That is a good focus. Biomaterials and dental restoration cover a lot of ground. Are you concentrating on restorative composites or implant materials, or both?
Both, actually. I am comparing nano-reinforced composite resins for posterior fillings with ceramic and metal implant surfaces that promote osseointegration.
Excellent. For composites, remember to discuss filler size and distribution. Nanofillers can increase flexural strength and reduce wear, but dispersion is critical.
Right. I read a study that added silica nanofillers to a methacrylate matrix and found improved mechanical properties, but the authors warned about agglomeration and increased viscosity.
Exactly. In practice, that means manufacturers optimize coupling agents and polymer chemistry. Silane treatment of fillers improves bonding with the resin matrix.
How about polymerization shrinkage? That is a persistent problem with resin-based fillings.
It is. Newer monomers and stress-relieving chemistries, such as thiol-based systems or addition fragmentation chain transfer, can reduce shrinkage. Also, incremental placement and resin-modified glass ionomer liners help manage stress.
You mentioned resin-modified glass ionomer. That material releases fluoride, correct?
Yes. Glass ionomer cements and resin-modified glass ionomer can release fluoride and provide chemical adhesion to dentin. That makes them useful as liners or for atraumatic restorations.
What about bioactive glass materials that are being marketed for restorations? Are they effective for remineralization?
Bioactive glass can release calcium and phosphate and raise local pH. In vitro studies show they can promote apatite formation on dentin and reduce sensitivity. Clinical evidence is promising, but long-term trials are still limited.
Turning to implants, I see a lot of work on titanium surfaces and zirconia implants. What are the current trends in surface modification?
Surface roughening by sandblasting and acid etching increases surface area and promotes osseointegration. Coating titanium with hydroxyapatite or applying calcium phosphate layers can further encourage bone bonding.
So surface texture and chemistry both matter.
Yes. Roughness at the micro and nano scale influences cell attachment and differentiation. Chemical signals from coatings like hydroxyapatite also guide osteoblast activity.
In one case study, I read the clinician used a zirconia abutment for a patient with a metal allergy. They also used a bioactive coating. Does zirconia have advantages over titanium in such cases?
Zirconia is ceramics-based and can be advantageous for patients with suspected metal sensitivity. It is also more aesthetic in the anterior region because it does not show through soft tissue. However, zirconia has different mechanical properties and requires careful design to avoid fracture.
You mentioned different mechanical properties. Do you mean modulus of elasticity and fatigue resistance?
Exactly. Matching the modulus of elasticity of the restorative material to that of the tooth or bone can reduce stress concentrations at the interface. Fatigue resistance is critical for long-term success.
That seems important for both crowns on implants and for direct fillings.
It is. For direct restorations like composite fillings, a mismatch in stiffness can lead to marginal failure and micro-leakage under cyclic loading and thermal changes.
Speaking of micro-leakage, are there new adhesive monomers that improve bonding to dentin?
Yes, functional monomers such as MDP form durable chemical bonds with tooth structure and with certain ceramics. Combining proper surface treatment of the restoration and adhesive selection reduces microleakage.
Are antibacterial additives being used to prevent secondary caries?
There are several strategies. Silver nanoparticles and antimicrobial peptides have been incorporated into experimental resins. Another approach is using ion-releasing fillers that create an environment less favorable to bacterial growth.
What about self-healing composites? I saw a paper on microcapsules that release a healing agent when cracks form.
Self-healing is an exciting area. Microcapsule systems and dynamic covalent chemistries have shown promise in laboratory tests. The challenge is ensuring biocompatibility and long-term stability in the oral environment.
For my review, I want to include regulatory and clinical perspectives. How do you suggest I address translation from bench to clinic?
Discuss in vitro mechanical and biological testing first, then cover animal models and early clinical trials. Emphasize that many promising materials perform differently in the complex oral environment because of saliva enzymes, pH cycling, and mechanical wear.
Are there any recent clinical examples I should highlight?
One useful example is the use of polymer-infiltrated ceramic networks in posterior crowns. Clinical reports show good wear resistance and reduced risk of catastrophic fracture compared to traditional ceramics.
And for implants, a case where a hydroxyapatite-coated titanium screw led to faster osseointegration would be relevant.
Yes. Also include a patient case where a zirconia abutment was chosen for aesthetic reasons and to address metal sensitivity. That will illustrate decision-making.
For that implant case, I would recommend a zirconia abutment with a hydroxyapatite coating to enhance osseointegration and reduce metal sensitivity.
That statement is clear and shows you are applying material science to clinical choice. Make sure to reference the evidence level behind each recommendation.
I will. Any advice on presenting the limitations of new compounds?
Be explicit about long-term fatigue data, aging under thermal cycling, potential cytotoxicity of additives, and manufacturing consistency. Also note cost and ease of processing for clinical adoption.
Thank you. This helps me structure the review. I will draft the sections on composite nanofillers, bioactive glass liners, surface treatments for implants, and clinical case summaries.
Good plan. Send me the draft and we will refine the figures and selection of case studies.
I appreciate your time. I will email the draft by Friday.
I look forward to it. Good luck with the writing.
Listen again to part of the conversation, then answer the question.
For that implant case, I would recommend a zirconia abutment with a hydroxyapatite coating to enhance osseointegration and reduce metal sensitivity.
This concludes the conversation portion. For more TOEFL practice tests and study materials, visit Spinta.org.